to our board meeting. We're going to go straight into the agenda. It's a very important meeting and I want to use all the time to enable us to discuss and debate the choices before us today. So first of all, any apologies for absence?
Yes, Chair, we've got Miss Sian Howitt, Mr Winston Weir, Miss Alison Shakeshaft and Miss Anna Lewis.
Thank you very much. And any declarations of interest? No. Should any arise during the debate, can you please indicate? So I'm going on to the one item on our agenda, which is delivering on our purpose, implementing the Healthier Mid and West Wales Strategy, the Land Identification Plan. So over to you, Steve.
Thank you, Chair. So I'm not going to say very much, but just a few opening comments. I guess I just wanted to sort of set this in a bit of context for us all. Today is about taking another step on the journey to realise the ambition that we set out in a Healthier Mid and West Wales back in November 2018. And it should be seen in the context of all the other things that we're doing to bring that strategy into being. Things such as the Cross Hands business case, the community discussions now underway in Fishguard and Llandovery, and the work in Aberystwyth to establish an integrated care centre there. At every step of this journey, we wanted to ensure, we've tried to ensure that we are deeply engaged with our communities, which I believe we have done so far. Our commitment is to keep going with that engagement. For example, this week, just meeting with town and community councils rather, and all of our county councillors recently. And we want to continue to engage with people, particularly those who have concerns about what is a very significant change in the way we operate. And I know the whole board will support the efforts we'll make to ensure that engagement continues. It's also, I would say, and we all know this around the board, a once-in-a-lifetime opportunity, long overdue in West Wales, to invest in the people and businesses that live and operate in the area. So I think today is an important step forward, but it is one step along a very long journey that we've been on for some time now. I think I would just end by saying, just acknowledging for members of the public who may be watching, there's an awful lot of information in these slides today. The board has already had an opportunity to go through that in detail, so it may feel like we're rushing through some of the information in order to get it all into the public domain, but that is no reflection on the fact that the board has spent considerable time considering these things already. So I'll hand over to Lee.
Thank you, Steve, and thank you, Chair. Thank you, Judith. So, first of all, I'd just like to start by introducing Hywel Dda, who's a member of my team who's joined us today to help with any particular questions in relation to the work done within the information packs. As Steve has said, this is part of our strategy that we agreed in 2018, which is fundamentally not about buildings and certainly not about the new hospital specifically. It is about a change in the model of care. Nonetheless, the new hospital itself is clearly an integral and important part of the delivery of that strategy, and we set out the changes and the investment required, long overdue, as Steve says, within the programme business case that came to board at the end of January and submitted to Welsh Government at the beginning of February. Each stage of this land appraisal process has come through board for endorsement and the agreement around the methodology, and board will be familiar with 5 sites that we've selected and then the 4 appraisal work streams that we established to provide evidence to consider further as to how we narrow that shortlist and eliminate any sites or sites from the next stages of the work. Covering ESPA within your pack is supported by the appraisal workstream reports. There's a lot of information, as Steve rightly says, plus more detailed dependencies. And then today we've got a presentation which is intended to help board members navigate through that information. So we focus on the key points. As we've said, we have talked at board seminar through some of the specific site information, and the board are asked today to consider 2 issues in particular. One is the site to take forward for further consideration, and then secondly, the need to undertake a public consultation. On that point, regarding the need for consultation, board members will note the meeting with the CHC as set out in the ESPA and the recommendation that we do consult, and we are recommending that today also that board approve that process following today's meeting, which we'll then bring back to a later board in terms of the specific details of how we would do that. The ESPA then also highlights that the number of sites retained does have a consequence for us. We will need to invest quite heavily in further scrutiny investigations relating to those sites. There will be a cost consequence to our programme depending on the number of sites that we select, and there's likely to be a timeline implication as a result of that as well. So the only other point I'd just like to pick out to the SBAR is that we will continue to work very closely with Welsh Government on the next steps. Clearly there's a lot of interest in it, and we want to make sure that we do that in partnership with Welsh Government. So if it's okay with you, Chair, my thinking on the way we handle the session today is we'll cover the first part of going through the factual information through the appraisals. I will introduce the technical site appraisal and the preliminaries. I will then also take us through the clinical with Phil's help. Then I'll ask Lisa and Hugh to come in on the workforce and the financial and economic. I suggest we pause at the end of each of those work stream summaries just to allow people the opportunity to ask questions or make comments. Conscious of the time, we'll try to move through all of that relatively quickly, because that's obviously repeating information that we've already shared with board, and then allow the second part to be the discussion, the deliberation around what we do from here, if that's okay. Thank you. So, without further ado, I'll then take us through the presentation. This is the structure. As I say, there's a lot of information even within the presentation itself, so I won't go through every single slide in a vast amount of detail, but I will touch on the key points for board members. So we start with a summary of all the appraisal workstream outputs. We'll go into detail, obviously, with each of these as to what they mean, the implications for us, but helpful as a starting point to just give that overview. And what we can see from the technical side appraisal is that we have the 5 sites scored there, 2 sites scored highest, site 12 and site 17. We then had site 7 and site C, and then site J scoring lower than that. What I would suggest in relation to that is that site J is around 10% lower than all the others, so that I think is a meaningful difference and distinction. The others are within a margin of around 8 points or so, which is probably not statistically significant, but I think the information that sits beneath that is instructive to board as well, because obviously each of the sites have scored differently against the different criteria. But we'll come on to that when we come into the technical site appraisal workstream. On the clinical appraisal, you can see the outcomes there. Again, we'll come on to that. There was a much stronger view in relation to peds, obstetrics and neonates, which you can see in the summary, but again, we'll come back to that. Workforce appraisal was not conclusive, but Lisa will take us through that. And then you can see the assessments of the economic impact, which Hugh will take us through. The technical risk scores at the bottom relate to that original work stream or the work relating to that. So there is a difference across those sites, and when I go through each of the sites, I'll draw out the relevant points that explain why those scores were higher or lower in each case. As a reminder, we have the 4 work streams coming to the discussion today. And before I go into it, just to say that we have requested an appraisal from the Quality Assurance Appraisal from the Consultation Institute. As Steve said, we have approached this with, we believe, with openness and transparency, and we sought some reassurance and some assurance from the Consultation Institute that if they appraise our information, that they come to that conclusion also, and I'm pleased to advise board that that is the conclusion that they've come to. That is just some additional assurance, I think, for board members that we've tried to do this in as open and transparent way as we can. Okay, so I'll move into the technical appraisal work stream. So board members will be aware of the work done up to this point. We originally went out to the public last summer to ask for nominations. That gave us 11 sites. We reduced that to 5 through a shortlisting process last autumn. We then finalised that in February and endorsed that through board, and we then commenced an appraisal, the 4 appraisal work streams that we've just referenced now. We then, for the technical land appraisal, we then went through a 3-stage process. Firstly, we determined the criteria by which we would assess each of the land through a workshop. We then went into a public process with, as we've mentioned previously, 52% representation from the public, and then 48% from a mixture of staff of all levels across the organisation. That followed then a criteria weighting workshop, so we weighted each of those criteria to determine their relative importance. And then finally we went through a scoring workshop at the end of June, both of which were facilitated by the Consultation Institute, which came to the results that I've just shown you, and I'll talk through as we go through it now. I won't dwell on these, but just to reinforce the point that we sought representation from our public and an equal representation, make that as representative as we could in a number of different ways. So we looked at geography, age, and then obviously protected characteristics as well, to make sure that we got as fair a representation as we can, recognising, of course, that that is still only a relatively small proportion of our population. The weighting that came through that first workshop is again shown here. Again, that's come through board for endorsement, since the key one that came through, or the highest that came through, was the transport and accessibility, which is in line with what we hear from our public when we have discussions around these plans. The second workshop, then, we went through each individual site in detail. We had technical experts presenting that information and answering questions. I would say it was a really engaging and lively discussion and debate. It worked well from that point of view, and we covered each of the key sites in some detail, and the key points were drawn out through that. We then asked each participant to score the sites against each of the criteria that we've just seen. Again, this is just a summary then of the representation that we achieved through that. It did prove more difficult than perhaps we expected. We struggled to get the representation in some areas in particular, and we did see some individuals drop out, which is to be expected in this process. That is a normal part of it, but just to make board members aware of that. Okay, I'll go into the sites themselves now for just a review quickly of each of them. So starting off with a map, just so you can get your bearings as to the relation geographically of each of the 5 sites. And then the scoring that came through each of those 5 sites. So we've got them going west to east on the screen, left to right. The raw scoring is what you see at the top. Now that reflects everyone who's in the room who scored. They came up with these figures, and then what we did was adjust. We asked the Consultation Institute to adjust those figures to increase the public weighting slightly in order to readdress that balance. So we continued with the 52-48 public representation. That obviously changed the absolute scoring, but also in some cases you can see it's changed the relative scoring between the sites. Okay, I'll go through each of the sites briefly in turn now. So Narberth site is 49 acres. It is to the east of Narberth town, around 1 kilometre from the centre and from the railway station. It's around 1 mile from the A40. The diagram on the right-hand side, just for clarity, is a test for fit within that site. It isn't a design or any proposal as to how it will look. It is purely a test for fit, and that is repeated then across each of the sites. The key points that come through some of the risk assessments and the other information, which are shown on the subsequent slides, we know there's so we know it's within reasonable walking distance of Narberth town centre, which is certainly a positive, and the railway station. That's an important point from a transport perspective. It is on a different line though, because the line diverts at Whitland, so there isn't a direct train line from North Pembrokeshire to Narberth, just for board members to be aware of that. It is in single site private ownership. There aren't any significant ground issues that we're aware of, but there is an issue with phosphates potentially into the Cleddau, which is impacting all planning developments at the moment within Pembrokeshire. What I would say on that is, whilst that is currently a substantial problem and would prevent us from building, what we anticipate is that either that might resolve during the course of the period of time that we are talking about, i.e. there might be a different policy in relation to that, or we might be able to design a solution into the final hospital design which could mitigate for that. But clearly there are some risks and cost implications and so on in relation to that. With 49 acres, it's above what we needed as a minimum and does give us a capacity to expand probably by around 20%, but not much more than that. So it's not the biggest site, but it does give us that opportunity to expand beyond that potentially. We will need to upgrade in a number of different areas, which is common to all sites. The other point to just note is that we will need to divert services on Site 7, 12 and Site C, which is one of the reasons why the risk score is higher, because if you look through the risk scoring, that is different for those 3 sites. Strengths and weaknesses are repeating in what I've just said. I don't think there's anything additional there that I haven't covered. Site 12 to the north of Whitland, between the town and the A40 itself. That is a 47 acre site immediately adjacent to the A40 in this case, and around 1 kilometre or so from the centre of Whitland town. It's similar size to Narberth, so does offer some limited expansion up to 20%, as we've talked about, but not a great deal beyond that probably. There are some points to pick up through this. So the site it has multiple ownerships. It's primarily owned by 2 landowners, again private landowners, but crucially there is a ransom strip in the middle of that site as well, so clearly there is the potential for challenging negotiations in relation to that. Again, no significant ground issues, and as per Site 7 we will need to divert services, which will bring some cost and some challenges. The Whitland railway station again is within reach. It is not quite as close as Narberth, but is pretty close, and as I said, it's directly adjacent to the A40. There are no known phosphate issues in relation to planning permission, but clearly we would still see the issue of potentially phosphate pollution, which we would need to mitigate against in some way. Then we have Site C, which is the largest of our sites, 157 acres, substantial site owned by the Carmarthenshire County Council, which is important because we believe that will make, it is the case that acquiring that site would be considerably more straightforward. There's an agreement in place between public sector bodies for transfer of land, so we wouldn't face the same kind of negotiations that we would face with other landowners. It is a little further away from Whitland town centre, depending on, of course, exactly how we design the site. There are some challenges within the site, though. So although it is a very large site, we do have 2 gas main pipes running through the south part, which is why in the test for fit on the right-hand side, you can see the hospital is indicatively shown towards the top of that site. What we'd want to then explore is acquiring further land to the north of the site, between what is shown here and the A40, in order to secure an alternative access point onto the site, and obviously support the road infrastructure changes that we would need to make there. So we'd probably describe that as access reliant on that additional land, and we have had conversations with landowners there. I think I've covered the key points. So that, again, the 2 high-pressure gas mains across the site, so we would have to divert. So technically that is possible, would come with costs, and obviously might limit the design exactly, and could come with some risks. The advantage of having such a site, such a scale of site, though, is that we could look to put other things on that land, such as accommodation for staff or for people who might want to use our hospitals or work in our hospitals. Or equally a solar farm, which we haven't included in our must includes, if you like, within all the other sites. So there are opportunities there to use that land for positive gain. Okay. And then Site J, which sits between St Clair's and Whitland, which we've categorised as St Clair's site. It's slightly larger, 67 acres. It's a gradually kind of sloping site which we can work with in terms of the design. Important points to note is it is 2.5 kilometres away from Sinclair's town centre, and it is outside of the local authority development plan. So that might have an implication for planning. It also has an implication for infrastructure and other services that we would need to provide to that site, because it is quite remote. The other key point is there's limited frontage onto the A40, and it's not immediately obvious where we would put a secondary access, and clearly a secondary access is going to be essential for a hospital of this nature. If there was a major accident, for example, on the A40, we would need to find another way into the site. To support that, it could do, therefore, with acquiring some additional parcels of land relating to that. Again, we could expand what we've got there in terms of footprint by around the 20% test that we've added as per the other two sites, but probably limited beyond that just because of the shape of the site, unless we were to acquire more. It doesn't require any diversion of services, though, which means it scores slightly lower on that criteria for the in the risk section. Okay, and then finally site 17. So this is close proximity to Sinclair's town centre, 0.5 kilometre away, and immediately adjacent to the A40 and the roundabout that connects the two roads there. It is the smallest of our site, and that is the main issue. If you look through the risk scoring, that is the fundamental risk challenge with that site. It is a flat site, so it is suited for development. And the two issues relating to the size are obviously one around pure expansion for our health services and any need for that. It also then limits our opportunity to do other things in that footprint. So the things I mentioned earlier around solar panels or accommodation, but on those points they could be to some extent developed in close proximity to the site. They don't have to be on the site itself. But clearly there would be some advantages to that, and we'd have to secure separate land in order to achieve that. The other point is that what we would like to do is use the land that we develop and the site that we develop to support biodiversity and other environmental improvements that will both be better for the local population and the environment generally, but also be a better environment for our staff and our patients. So we're not precluded from doing that on this site, but clearly the more acreage we have, the better. There is an adjacent site which, if you look at the right-hand side, there's a parcel of land to the top left-hand corner outlined, which is another additional parcel of land that we are looking at, that we could potentially look to acquire to address that, and that would bring that site then approximately in line with the Narberth site and the site 12 in Whitland. Okay, the only other points to note are that there isn't a train station in Sinclair's currently, which is again one of the risk factors that score higher for this site, but there is a train station funded and approved and planned, so that is in progress, and we're expecting that will be in place before the point at which we'd be looking to build the hospital. But clearly that isn't in place at the moment, and we need to bear that in mind. It is in single private ownership, and there are, again, similar to the other sites, need to significantly upgrade the water, electrical and drainage infrastructure, but no need to divert services as we have for 7, 12 and C. So I think I've covered all of those points. So I've given you a quick run through then of all the information that was discussed at the technical workshop, and with that information the participants were asked to then score them, and obviously we added them all up, and you can see the weighted total scores in front of you now. So clearly what you can see from this is that there's Site J consistency scores a bit lower in a number of areas. There was a lot of discussion about Site J in the workshop itself. The other 4 sites, some are stronger in one aspect, one criteria, and weaker in others, and vice versa. So there's a bit of a mixture across the different criteria as to how well they score. So no site is perfect, and we were expecting that. And then just to go back to the evaluation of the risks, so I've talked through all the risks now, and the details in the pack for board members, but just to summarise where we ended up. So 3 sites score lowest being good, site 12, site C and site 17, or better I should say, and then site 7 and site J score a little higher for some of the reasons that I've outlined. So I will pause there and ask board members for questions or comments on that technical site appraisal. If that's okay.
Thank you, Lee. Very comprehensive summary of a lot of detail that we have in our papers and have considered. Open for questions, members. Judith.
Yeah, thank you, Lee. Thank you for going through that, and thank you for the papers. I just would like to ask a question and just understand this issue of being outside the local authority development plan, which impacts quite a lot on the risk score. But I suppose my ignorance is I'm not sure of the implications of that. And my second question is around the impact of the ransom strip, and just how much of an issue that potentially could be. So 2 points, if I may.
Happy to take that. Thank you, Judith. So on the local development plan, so clearly each local authority is required to set out their development plans for for these different areas well in advance, and set out where they would look to and propose to develop either residential or other buildings. Sites that sit outside that, it does not mean that they could not be considered, but clearly that would require further discussion with local authority, and it would be another hurdle for us to overcome in order to get to that point. What it does mean, though, I guess part of the reason they're not in those local development plans is the challenges in developing in those areas to begin with. So some of the reasons that I've outlined, particularly around Site J, would be concerns for the local authority as to how that might be, how we might develop those in the future. So we shouldn't. So that doesn't preclude the Site J in particular for as a result of that, but it is an obstacle we would need to be aware of, and that would be outside of our gift as well to some extent. Sorry, I've forgotten your second point now, Judith.
Ransom strip.
Oh, the ransom strip. Yeah. So the ransom strip question. So clearly, as I've said, when we're negotiating with public sector partners, it is a much more straightforward negotiation. Because there's a district valuer assessment of the land, and then there's a prescribed process as how you then would handle that transfer and the resource transfer associated with that. When you get into a private ownership discussion, then that is clearly dependent on the individual's willingness to sell at or close to a value that district valuer's evaluation of it. So the ransom strip is important in relation to Site J, but Site 12, sorry, but that point applies to all of the ones that are in private ownership to some extent, and the more landowners we have, the harder that negotiation is likely to be. Now, so we know, for example, through the discussions with the different landowners, that there are differences in individuals' valuation of the sites, and therefore there will be some risk associated with us closing that gap between what we would assess the value as and what we'd be able to pay for it, and then what individuals would want. And some of that might depend on what they think the land could be used for in the long term, like residential development, for example. In the case of the ransom strip, that is obviously a special case in that that would have limited value for other things other than the fact it sits in the middle of a site, which if it was developed, where it significantly increases the value. And we know that through, in other places, the ransom strip negotiations can go on for a very long time, and so it brings in that uncertainty.
Okay, thank you very much. Thank you.
Thank you. Delith.
Diolch, Chair. Diolch, Lee. I've got 2 questions, and I'm not sure if one question can be answered a bit later.
Okay.
But it's about access and transport. And you've mentioned railway stations, but a number of our population cannot access railway stations. They will be accessing it via their own transport or even buses. And I am slightly concerned. Can you explain to me about the transport infrastructure on the roads? Because as we know, West Wales is quite a tourist hotspot seasonally, and we have got seasonal traffic. So can you explain to me what other modes of transport that we have considered? And the other issue I've got is the number of the public that have been involved in this consultation so far. Are you confident that we have heard the quiet voices, the seldom heard voices, that we're going to be further increasing our methods of engagement? Diolch.
Yeah, thank you, Dalith. So, transport and access comes up a lot in the discussions, and it's a real concern for our public. We're very aware of that. We've got some substantial information in the packs in relation to transport analysis, and you'll see from that, and it was presented at the workshop, that there are different modes of transport that we've looked at, analysed the impact all the way through from walking, cycling, public transport, road, and so on. I think there is a reality in clearly the geography that we're working in. We know that is going to be a challenge. So what we have analysed the access time information, and some of that we do come on to that a bit later. One of the points that came up through the workshop discussion was the time of day that you choose to do that analysis, and clearly what we've not set out to do is analyse every point during the day, if you like, and worst case scenarios, and we're very much aware that there is significant variability around what might be the average travel time and measuring that. So that is a concern for our public, and that is understood. What we don't have at the moment is very good bus routes along that A40 route. So there's a level of bus service within counties, within Pembrokeshire, North and South, and within Carmarthenshire. There's less between them in the A40 zone that we're considering. So I think that is a real concern for us and for our public, and something we're going to have to work on over the coming years. When it comes to using that information to distinguish between the sites, I think if you look at the way in which it was scored and so on, whilst people recognise it as very important, which is why it scored very highly on the criteria, there was less of a distinction between the sites as to which one was better for that reason, because whether you're travelling slightly further west or slightly further east makes less of a difference to the fact that actually the transport options are limited there anyway. So it doesn't come through strongly as a distinguishing factor between the 5 sites, a differentiator between them, but we know it is a real concern and a real issue. And we have, as you'll be aware, we've done work with Transport for Wales to understand the options to try and improve that, and we've referenced the train station, that there will need to be improvement to bus routes equally. Clearly, though, we know that most people will still travel by road. That is the reality of our situation. So, again, there are some improvements going on at the moment, but that is a fact of life, I suppose. We're going to have to try to work through. On the point of engaging with seldom heard voices, so you'll see from both the technical workstream appraisal, but also in the EHIA approach, we've gone out and sought views quite substantially. So on the EHIA, we had, I think from memory, it was 700 or so responses, skewed, admittedly, to Pembrokeshire in particular. I think we need to acknowledge that, but there were quite a lot of voices coming through that. And through the participation in the workshop, we sought a range of voices. So I think what I would say is the messages and the comments and the concerns we're getting through in relation to all of these sites is consistent in all our conversations, and through the EHIA we've drawn out some of those key points, and they align actually with the general public concerns. So we've done our best to do that. But I think your question there is one of the reasons why I think we probably need to consider the consultation item, which we'll come back to in the discussion. That's okay. Thank you.
Yes, sorry, Chantal.
Thank you. I just wanted
only because I'm new and I had to absorb.
Chantal, do you want to use your mic?
I had to absorb all 657 pages over the last 2 days. I just wanted to understand a little bit more about the weighted total scores, how we've arrived at those, in order for me to kind of have an understanding as to, you know, which one are we giving priority to and what's features a little bit higher for us in terms of making a decision. Thank you.
Thank you.
Yeah, so the criteria, so there's a three-stage process, as I said. So the criteria were developed, or the 6 criteria were developed through a workshop. We then asked through a public workshop, we talked through those criteria in quite a lot of detail and explained what we meant by them, what was kind of under that overall heading, if you like, because there's a number of different factors to each of them. And we then got public and staff representatives at that workshop to weight those criteria, which is how we ended up with the criteria that we had, the weighting of those criteria, and then we went through that scoring process to allocate scores to them following that. We did finally, as I did mention, we did then tweak that scoring to reflect or to reinstate the balance that we were aspiring to, which was 52% public and 48% staff, and that then changed that dynamic very slightly as the public weight took put a bit more emphasis onto that. I think I would go back to what I said at the very start on this, though. We have got 5 sites, which obviously the reason we got them through this far was we thought they were all viable. From a technical point of view, they are viable. So it's not a surprise that they're relatively close together. But I think what you can see is that Site J scores consistently lower and 10 percentage points lower than the others. The other 4, I think there are strengths and weaknesses. I don't think it's statistically significant, the difference between them from the technical site appraisal point of view.
Thank you.
Thank you. Ewan.
Great, thanks, Chair. Firstly, I just want to, thank Lee and all the team for the immense amount of work which has gone into this. I think it's, fantastic for us as members to have this depth of information to really kind of go through and reflect in terms of the amount of consultation which has already been done and will continue to be done. Whilst the scores appear quite clear in terms of the rankings, I think, as we know, sometimes we have to look at the bigger picture. And I'd be keen to kind of see if there's any further insight into the future proofing. And in terms of that, what I'm thinking is this is a once-in-a-generation opportunity for West Wales. Now, if you look at the site, Site 12, as you say, came out on top in terms of the scoring, 47 acres, just under 20% capacity for expansion. What I'm kind of looking at is Site C in Whitland. It's 157 acres, local authority owned. So that may ease the kind of opportunities in terms of the land purchase. We're working with a public sector partner who wants to see investment and expansion within our region. But also, I'd be keen, did the consultation identify in terms of that future proofing that not only do we have a new kind of hospital, but the opportunities it could afford us on such a larger site for affordable housing, opportunities for enterprise. We're going to have a huge opportunity in terms of the economy for supply chains. We could look at part of that 157-acre site being kind of promoted for local enterprises who may be part of the procurement and supply chain opportunities for that new hospital in terms of food, services, ancillary services and so forth, but also as a hub for our wider communities, as a space which isn't going to see them held to ransom by private landlords in terms of rent, but it's also a site where we can look at housing, business, economy, education and skills as part of this huge site, which allows us to future-proof. Because as we've seen with our current kind of stock, we're at capacity. We haven't got room for growth. And if we do this right, I think we've got to look at the future generations that we have a responsibility for, as well as our communities. So I'm just, after a long-winded kind of overview, I'm just keen to see, did the future proofing come through from the public, or are they just looking what's in front of them and the immediate issues, rather than thinking the opportunities this once-in-a-lifetime generation affords us?
Yeah, thank you, Ewan. So you're right. Clearly, Site C has more opportunities from a physical size point of view. So firstly, it will be easier to acquire, and that comes through in the risk ratings and the scoring from that workshop. So that first phase, undoubtedly, that is the lowest risk option in that sense, at least from an acquiring point of view. But just to pick out the point around the gas mains and the fact that we probably would need to acquire additional land to the north of it, so that then does bring in a private owner. So I would say that through the workshop discussions, certainly the sheer size of that site, albeit there are some limitations as to how we could use it because of the gas mains, for example, was recognised as an advantage and could give many of those opportunities that we just talked about. So that was certainly part of the consideration and should be part of our consideration today. Equally, there were then some other risks and challenges that I've referenced that kind of weigh against that as well. So I think, like all the sites, there are advantages and disadvantages, and to some extent it's us weighing those up, and there will also be a need for us to get some further information on these sites as well. So we don't know everything at this point. So as much as the work we've done, there is clearly further to go with some of these sites, particularly with negotiations with landlords and so on. And in your wider point, I guess what us owning land would make it easier for us to do some of the things you've talked about. But equally, any of the sites they have land opportunities around them that could offer those opportunities in the long term. We haven't explored every single piece of land to see whether we could acquire them in order to get us up to 100 plus acres, for example. That could still be done at a later date.
Are there any more questions on the technical appraisal workshop? Okay, thank you. We'll go on to the next, the clinical appraisal. Thank you.
Thank you, Chair. I'll introduce it, and Phil has worked with me on this, so I'm sure Phil will want to add some points as well. So, just in terms of process, first of all, we, as part of our strategy, we obviously designated the zone as the area within which we would look to be building the new hospital. That was following a lot of consultation, engagement and analysis back in 2017, 2018. So, therefore, our default position, if you like, was that anywhere in that zone would have been suitable from a clinical point of view in order to deliver services. We knew that was not going to be entirely the case, though, because through the engagement and consultation in 2018, there was particular issues identified through peds, obs and neonates, so we knew we were going to need to do a further piece of work on that. That was agreed at the time. And of course, 4 years have gone, so we wanted to test back with the clinical teams as to whether there were any other services that we would need to consider in addition to that. And we went out, we asked viewpoints on that, we sought clinical views as to whether that was the case. And the majority response was actually anywhere in the zone can work. There are clearly implications for that, but from a point of view of sustainability of services, the consistent view was that could work. The exceptions to that, or the areas that we wanted to test further, were clearly peds, obs and neonates, as I've already talked about, and then we added stroke to that, recognising that stroke models around the UK are changing. They're moving to more of a HAZU, hyperacute stroke unit model, centralisation. So we wanted to just explore whether that the location of the hospital might limit our options in that regard. So we held workshops similar to the technical site appraisal in order to assess that, and we then asked attendees to rank the three locations, and the outputs from those workshops are in the pack individually, and then we've got a summary report to draw out all the key points in relation to that. The key findings, as I've already referenced at the summary, were from a stroke point of view. First of all, if I cover that, the view was that anywhere in the zone could work. It was less about location, it was more about what services and facilities would be available in the new hospital. But clearly there was a recognition that the further east the hospital is sited, the greater activity would be in that unit, and therefore equally the fewer of our residents would need to access services in Swansea Bay. Equally, there was a view that the further east might attract more of particularly the senior clinicians to come and work in the unit because of its proximity to major conurbations like Swansea and further afield. That was obviously a viewpoint, and we'll come on to workforce in general later. The neonates, obstetrics and peds workshops were much more definitive in their view, to the extent that, as you'll see in the pack, their view was actually the zone itself does present a risk to the sustainability of some of those services. But within that, then clearly there was a view that the further east, the less of a risk that there would be associated with that. Now, what we've done in support of that is test those outputs from both those workshops in a number of different settings. We've tested them further with other clinical groups and with other groups like the Stakeholder Reference Group and Health Professionals Forum and so on, just to get underneath that. And we've also engaged with members of the public to just try and test some of those conclusions. And what I would add as well, I would draw your attention to the data analysis, particularly on births, which is on page 31 of the clinical appraisal, so page 298 of the overall pack, which gives us a sense of that, of our best estimate of that impact on birth numbers in the new hospital. So there are unknowns in this. We can obviously work on the basis that people will travel to their closest hospital, which is our starting point. But what we know is that actually people already travel a little bit further in order to go to the hospital of their choice for a variety of reasons, and some other information in the pack as to what those reasons might be. But some of them are relating to continuity of care and where they want their children to be born in case of births. So there's some uncertainty in relation to what people's behaviours might be. What we do observe, though, from current behaviours is that we think a 10-minute additional travel time, we observe people are willing to do that now. So if we extended that to our modelling for the new hospital, then that gives us another set of numbers. But fundamentally, because we have obstetric-led services already centralised at Carmarthen, the movement from Carmarthen to east to west across that zone we do anticipate will result in a loss of births, and there's a range of scenarios associated with that. Worst case scenario would obviously people travel to their closest hospital only, but if you make that 10-minute allowance, then that changes that assessment, albeit there is still then a sliding scale of activity which we'll come on to a bit later. So that was the heart of the concern from the obstetricians, and by virtue the concern from the paediatricians as well. So they are the key points from that clinical appraisal. I don't know, Phil, if you'd want to add anything to that.
Just a couple of
Please.
things. Thank you, Chair. So first thing perhaps to say is that I'll also focus on obstetrics and paediatrics, because that was the key concern, and perhaps just reflect on the importance of obstetrics and paediatrics maternity services for our population and for the integrity of that of the new hospital. I suppose if we weren't to have obstetrics and paediatrics within the new hospital, it would affect all other services, and I think, you know, therefore it's really important that we do when we do build a new hospital, that we're as certain as possible that we will have sustainable obstetric and paediatric services within that hospital, because it will otherwise threaten other services and all sorts of provision for our population. The issue is the other point would be is that if we didn't have obstetrics, maternity and paediatric services within the new hospital, it would mean that the nearest obstetrics, neonatal and paediatric unit would be in Singleton, which is a long way from, particularly from the Pembrokeshire population and Ceredigion. So I think it's a really key point, and we need to listen very carefully to the clinical voices that we have. Just a couple of other points. there's a focus on the 2,500 number. You'll see as Lee pointed us to on page 31 of Appendix B. And the 2,500 number comes from a Royal College of Obstetricians and Gynecologists report back in 2010, and it was considered to be the amount of births in total that an organisation has to be able to maintain a training facility, because in that situation there will be enough of the common and rarer cases to train junior doctors, but also to allow consultants to keep themselves up to date, and midwives, and so the whole system is able to keep up to date. So whilst the documents you'll see on that page in 2021 and 22 from the Royal College of Obstetricians and Gynecologists don't mention that number, it's the peer-held view that around when you start to get below 2,500, that starts to threaten the sustainability of the unit. And other reports suggest that small units really are those when you get down to 2,000, 2,200, and then you really do start to get into questions about sustainability. And I suppose that looking at those reports, they do talk about, from the Nuffield Trust and the Royal College, about the concern about health inequalities if maternity units are a very long way from local populations. And because of some of the uncertainty that we have, that Lee has talked about there around the modelling that we've done, you know, we've looked at, for good reason, a factor that would allow a 10-minute preference for our hospitals, because we know that's roughly what there is now. Of course, there's some uncertainty in that. There's some uncertainty in birth numbers. There's also uncertainty in the position of future facilities in Swansea Bay, that we really do, I think, need to pay attention to the amount of births we have in this unit, because we're setting something up that could be there for the next 50 years. So it's not just for us now, this is for future generations. Thank you.
Paul.
Thanks. And on that last point, since we were undertaking this exercise, some of the data from the most recent census has come out, and obviously that's evidence what the changing demographic of the population in this area is, and to what extent have we been able to model that data in these figures to be able to establish where we... Oh, sorry. To what extent have we been able to model the data that's come out as a result of the recent census activity to be able to impact on these figures?
Yeah, I'm happy to take that. So the figures that we have that I pointed you to on slide 31 are not projecting forward on that basis. They're a reworking of the actual activity that occurred in 2019-2020 on the basis of the postcodes of those individual patients, because obviously we've got a meaningful comparison then as to what their travel times might be in the new configuration. So it's an important point there, Paul. You're right that activity reflects what happened a couple of years ago. We have seen over the last 20 years a declining birth rate in our area, and the forward projections are that the rate of that decline will slow, but we will still see some decline over the next 10 years. And then beyond that point, at the moment, it's predicted to be a levelling out of the births. So we will expect to probably lose another 200 or 300 births from our total, just naturally, putting aside any changes in configuration. So that is an important consideration, because that is uncertain. We clearly don't know what will happen, and all sorts of things can happen in that sense. But with the information we have at the moment, it would suggest that our birth numbers will fall to some extent over the next 10 years, and we have to bear that in mind in terms of the headroom we've got above that 2,500 or so indicative level.
And Lee, currently they're around 3,000.
Yeah, we've got just over 3,000 births across. Sorry, let me just pull up the slide so I'm correct in exactly what I say. But we have. Oh, you've got it. Thank you. So we have. So within our geography, so across our resident population, we have 3,183, and then 260 of those are currently going to Singleton. So our internal number, as you rightly say, is around just short of that 3,000 mark. And then you can see what we've done in terms of the modelling there, where we would suggest that we would probably lose, it would be a few hundred births, depending on how far west we were to place the site, as to how many births we would potentially lose, in addition to then the natural loss that we hadn't modelled in.
Thanks.
Sorry. Could we look at it the other way as well in relation to strokes? Because the population is ageing, and maybe that will also, maybe that's not so sensitive in relation to a HAZU, but is there any modelling as to whether there's any impact from a stroke perspective on the of having an ageing population and the likelihood of increasing numbers of strokes?
So on the stroke numbers, at the moment they're relatively consistent, is my understanding. But the over recent years, projecting forward, clearly age demographics would suggest that we would see an increase, but equally through better preventative medicine, better care, and so on in the community, that would offset that. So at the moment, our indication would be it would probably be about the levels that we're working at now, but obviously there's a degree of uncertainty around that as well for the same reasons.
Phil, you want to come in on that?
I think that, yeah, increases in number of strokes, I think, are because if we have an older population, as Lee says, it's likely that proportionately we will have more strokes. I think the consideration with that is more about how we build the capacity within a unit in the new hospital, rather than a concern over sustainability.
Could I ask a question on the stroke, please? The general findings say there that any of the areas would be suitable with pathways, in particular how patients are treated beyond their initial admission being more important than location. And yet when we dig into the body of the documents which we have before us today, it says when questioned with stroke, when questioned, will the Western area, Narberth, allow for safe, sustainable, accessible and kind services for the majority of stroke patients? The response of the majority of the participants was no, and they were asked to rank the areas between 1 the best and 3 the worst, and Narberth received the lowest score, and in the ranking poll was considered unanimously the worst. And then in the face-to-face workshop on the 29th of April, most people felt that Narberth could not provide a safe, sustainable, accessible and kind area for siting the hospital. And I just wondered if you could comment on that.
I'm happy to, and if Phil wants to add anything. So I think probably through the workshop, the discussions and the considerations evolved, I guess, as people were sharing their thoughts and sharing their perspectives on it. I think to some extent it depends what type of question you're trying to answer. So we obviously provide stroke services on 4 sites at the moment. So could we provide a single stroke service in the new hospital, which would effectively be combining the Carmarthenshire and Pembrokeshire population and the clinical teams? Well, we do more than that now. So it's reasonable to suggest that for them to have concluded that, of course, it is possible to do that. When you get into the nuance around that, though, of course, what that means for the same reason as obstetrics and pediatrics, the southeast of our population, ambulances will take those individuals to the closest facility available to them. So inevitably, the further the hospital is away from that population base, the more will flow into Swansea. Now, Swansea have a stroke service. They're planning to develop a hyperacute stroke unit. So it's, again, it's certainly possible for us to request that a larger proportion of our population flow that direction and the remainder go to the new hospital. What that means in practice, of course, is that we have, depending on whether it was Narberth, Whitland or St Clair's, we have a different size stroke service in that hospital. And whilst it is certainly possible to continue to provide services. What we wouldn't, we'd have we'd have fewer economies of scale, if you like, in order to meet those standards and those objectives. So we could over-invest, if you like, in order to secure that, if we could attract the workforce in, so which is where their concern came in relation to that. So clearly there's that choice about activity drives resources to some extent, which drives the viability of the services. So it's possible and can be done. We would suggest, at least in the 10-year time horizon that we know about stroke services, but clearly there's a trade-off there between activity, scale of the unit, and therefore the longer term options for us in terms of stroke services.
Could just follow up on that. What you're saying, both in respect of obstetrics, neonates and stroke, is the potential impact on Swansea and their capacity to absorb, depending on the site that's chosen.
Yes.
Yeah.
Yeah, absolutely. So we know there's, wherever we site the hospital, there will be an impact of some level into Swansea, and we've obviously shared that with the Health Board and had those discussions. But the exact siting will make quite a difference, and you can see in the birth numbers the scale of that, and similarly the stroke numbers. So we are 7 or 8 years away from the new hospital, so there's opportunity to plan for that. So we can do that to some extent, but clearly that has an implication for them as well as us.
And as you say in the table, the clinician's preference was the further east of a site.
Yeah, just following up on that, I guess whilst we looked at these two particular services, I guess we just need to have in our minds, the further we do go east, the less resilient, I guess, all of our clinical services might become, because we get the flow going into Swansea. So
further west.
Sorry, did I say east? I meant west. Further west we go, the less resilient and critical mass we may have in all of our services. Now, that might not make a difference in particular areas, but it's just something to bear in mind for all the other things that sit around the direct delivery of services, such as ability to attract, as you say, but also clinicians' ability to develop their skills and so on in subspecialism. Yeah. I guess it's something we didn't ask in this, but I guess it's just something to be aware of.
Yeah, and just a quick comment on that. So clearly, generally speaking, there is a relationship, a correlation between activity, resources, and then the range of services you can provide. That is repeated across the UK. It's not a clean relationship, and obviously there are all sorts of factors affecting that, but that is the general relationship. The one thing to just add on to your point there, Steve, is what we were considering as the services that we provide today, or what we know about could be provided today. There's a whole host of services that might be developed over the next 50 years that will as the new novel services and treatments will require a certain population base, a certain activity base in order to deliver those. So we can't assess them. We have no idea what they might be in many cases, but that is relevant, I think, to the point you're making.
Many thanks. I'm going to bring in Phil on the same point, and then I'll bring Judith.
Yeah, on the same point, just on Steve's point about thinking about all of our services, and the further west that we go, that there's inevitably going to be slightly more patients going into Swansea Bay. I mean, there would be there'd be the question of how they would build that capacity into their system. Of course, we're in close contact with them about our thinking, but also the flow of resource that would have to follow that from us to resource that additional capacity. And there's no doubt from if that resource flows, then as Lee's point becomes important, then that we would have less resource to build a critical mass for our services.
Judith.
Yeah, thank you. And if I could go back to the obstetrics discussions, and I just wondered how much was factored in to the outcome of this on the relationship with midwives. I meant the relationship between the woman and the midwife, because often that relationship is what influences, excuse me, where a woman will go to deliver. Now, obviously, a local MLU, midwifery-led unit, would be a factor there, but actually in terms of, unless it's an emergency, if your midwife is attached to a particular unit, particularly if they're rotating in and out, then to suddenly be taken somewhere where you don't know anybody is a huge factor. So I couldn't see in all the information whether that came out at all in a strong way.
Last, Phil.
So our midwives have had a strong voice in these discussions, and we did discuss what mitigations might we be able to put in place to reduce the flow across to Swansea of pregnant ladies about to give birth. So we considered the point about midwifery-led units close to the border. What was the strong view actually from our midwives and also from our medical staff was actually that, as you said, the relationship building between the midwife and the lady is the important, and the mother is the important factor, and actually having really strong antenatal care facilities along the border, in Llanelli and Amman Valley, could be really a really important mitigation. It won't completely mitigate the challenges, because I think the challenges that Lee and I have expressed are real, but that would be one of the mitigations we want to look at, I think, around how we establish really strong antenatal care in offer locally in Llanelli and Amman Valley.
Thank you. Okay. Thank you. Hansel.
Yeah, thank you, Chair. I just want to mention about the 3,000 births at the moment, Phil. As part of the Swansea Bay transformation, is it right that they're looking to move their paediatrics and obstetrics to Morriston? And if so, would that not push more of the East Carmarthenshire mothers towards, because it's easier to get to? And there's not many births would be needed to be lost in relation to their being non-viable, and mainly because of the fact that mothers are concerned about the travel at the moment. I know it's all about pathways, but is that more of a concern as well? And can you give some reassurance of the mitigation on that?
Yep. Thank you, Mansell. So there was a plan that Swansea Bay had to move obstetric care to Morriston Hospital. Then their plans now are to maintain obstetric care within Singleton Hospital, which, as you say, if it was in Morriston, that would be more difficult for us.
Thank you. Thanks, Mansell. Any other questions on the clinical appraisal? No, thank you. We go on to the next.
Okay, thank you, Chair. So I'm Lisa Boston, Director of Workforce and OD, and led on the workforce appraisal. So just to give an overview, our group considered the impact on attracting and retaining a workforce which was linked to the 3 zones rather than the actual 5 sites. So we considered Narberth, Whitland and St Clair's. And we looked at whether any site was more advantageous than any other. We considered the amenities in the local areas, the impact upon any staff that would be linked with travel, and also any wider considerations around staffing in a hospital within that area. We also considered our staff views via an online internal survey and drop-in centres. So when we looked at the 3 areas in turn, local amenities, each of the zones have similar local amenities, and therefore with the opportunity for wellbeing being incorporated into the design of the new facility, no zone was seen to be more advantageous than another. In terms of travel, the travel data that we gathered, which looked at people's current travel patterns, so from their home to their current work base versus their home to a new work base, it was evident that on those sites, either of them would lead to more travel for some of our staff. So the further east it would be, our staff who live in Pembrokeshire would be travelling further, and the further west, our Carmarthenshire staff would be travelling further. So therefore, again, there was no site more advantageous than others. When considering the two areas, it did become apparent, however, that we can split our workforce into two groups. So we have our general workforce who tend to live locally and are in easy access to their work. These staff tend to be the ones who could also work in a variety of sectors. So if you think about hospitality, estates, administration. And we then have our healthcare professionals where employment opportunity is more restricted. There are some opportunities, but it is more limited. But they also tend to be a more mobile workforce and are used to travelling some distances to get to their workplace. So in terms of the wider considerations, we looked at the 12 miles between each of the furthest west and the furthest east site and didn't feel that that travel distance was too large to deter movement within the zone. So it was felt to be a commutable distance within that area for anybody who chose to join the health board. The staff questionnaire and drop-in sessions that we did, whilst they produced some responses from staff about what was important to them and whether they would consider working in one of those three areas, and also how long were people prepared to travel for, it was a low response rate. But it did give us some very good intelligence around the fact that over 50% of the people who responded said that they would be prepared to travel to those sites. Slight variation in those. But what was really important for people was well-being and access to amenities. So the wider thing, which then doesn't particularly impact on any of the zones, is what's really important is that we have robust workforce planning. We need to use our regeneration framework. So how do we go about retaining and recruiting our workforce so that we can make sure we put mitigations in place for any of the sites that were to be selected so that we could reduce the negative impact on any of our staff who do need to move their base. A robust, clear recruitment strategy will be necessary to ensure that we have key actions in train to support the recruitment of new workforce. And the general requirements, regardless of where the hospital is within the zone, will be things like things that staff told us were important: access to training, access to research and innovation. How do we link with wider university links in our local colleges and schools? Good accommodation to support trainees and individuals who need to be on call. A robust travel plan to help staff with movement. Excellent wellbeing facilities on site so that people can take time to rest. Work and engagement with our staff will continue as we move forward, and we will work with our schools and colleges to support the workforce of the future. The existing hospitals will continue to play a significant role in the care of our patients, and therefore we will still require a workforce on each of our current sites. And therefore it's really important that we continue our dialogue with our staff and with our population around the workforce that we will need still in our current locations as well as the new location, and that we have a process to give assurances to people that not everybody will need to move. So in conclusion, from our group, we felt that there was no clear differential between any of the three zones. No one came out as being identified as better or worse than the others.
Thank you, Lisa. And what's becoming apparent the more and more we go into the evidence, it's really rich for the planning. Whatever the outcome, it's really rich. Any questions in relation to the workforce? Judith?
Yeah, thank you, Lisa, and thank you for all the work on this. I just wonder whether the access to affordable housing is something that was flagged at all, or whether that's something you're picking up in trying to attract. Because within the plan there's a lot of data about house prices and actually how Pembrokeshire compares with some of the higher areas. Ceredigion is even above some of the higher areas in Wales. So I just wonder, and I suppose linked to the conversation we had about one of the larger sites, so under consideration, whether that affordable housing or the access to housing for people in training, whether that came up at all?
Absolutely, it did. I mean, accommodation is important for all. We are aware in each of those three areas there are current developments underway in terms of housing. For our staff, we do need to have that accommodation to support, as I said, trainees and recruitment, so that we can at least help people if they move into the area before they find where do they actually want to live. So it would be an essential part for us moving forward.
Okay, thank you.
If I could reinforce that, in the BAME Board Advisory Group, it's often raised with our overseas recruitment, the difficulty in accessing even the higher grades doctors. Just getting accommodation is a challenge, and we need people to come and work for us in our area. Any other questions on workforce? Ewan.
Sorry, we're sharing a microphone here. I think, again, it's great in terms of the engagement which has been done with the current staff, obviously, across the Health Board. And I think, as you've already noted, Lisa, the kind of opportunities this affords our future workforce is something which can't be underestimated in the opportunities for our region. I mean, there's all these comments which are flying around as of this week. I mean, there was a campaigner saying that Hywel Dda should be, looking to, have these advertising campaigns to recruit more people in. Well, where have these people been? Because if they haven't looked at our social media, our YouTube, and the fantastic campaign which is already there to attract people into Hywel Dda, then there's something which is obviously there's a disconnect, I think, in terms of the communication side of it. And I know you've already started the kind of work with our FE colleges. And I think what may be useful as this hopefully progresses as a proposal with Welsh Government is not only to talk about, the wider opportunities, but perhaps for our public to perhaps put some quantities on the number of opportunities within the new facility as well, because I think that'll start to really resonate with the public in terms of their children who are currently going, kind of perhaps end of primary, kind of year 6. So when they go into comprehensive, they know that in kind of 6-7 years' time, this is the educational pathway they should be taking to have these opportunities on their doorstep, which are well paid, kind of opportunities which are there for decades to come. It's not something which is a short fixed term European funded project. This is a really serious opportunity for our labour market, supply chains, and for our future generations. So I think as soon as we can get some kind of numbers potentially out into our communities to really kind of curtail some of the criticisms and to really kind of demonstrate that we are kind of making a huge impact on our socioeconomic impacts for the 3 counties, I think that'll be really welcome. But I think, what's being done already is great. But I think as soon as we get those green lights to take us forward, let's get that information out to those parents, our current labour market who may wish to retrain and come in to work with Hywel Dda. And let's not forget, it's not only the new hospital, the investment which is going into both Withybush and Glangwili as part of this wider 1.3 billion programme will also require new skills. And we're going to have our current kind of workers who will be coming close to retirement age, so we're going to be needing to kind of refill posts. So there's fantastic new opportunities within our existing facilities, as well as what we're looking at in terms of the new hospital as well.
Yeah.
Just to respond to that, absolutely key. We have just entered into strategic partnerships with our secondary schools in terms of how we will be proactively working with them around future careers. And I think I mentioned in board last week, it's our primary school leavers of this year that will be our new recruits when the new hospital opens. So that is where we have to be now in terms of talking to people about some of the alternative routes and the traditional routes into education and to professional careers, and reminding people about just how many careers we have within the NHS and not just the top 3 or 4 that people think about.
Yeah, and building on that, Lisa, I wonder if you could remind us the work that you're doing to negotiate in relation to trade apprenticeships so that we have a workforce ready not only to build the new hospital, but to build, to refurbish or rebuild the existing hospitals and the integrated care centres.
Yeah, so we're working with an organisation called Covler, They work with our construction, the construction industry, and particularly the employers in that industry. They're associated with Carmarthenshire College. We have a meeting with them on the 1st of September with the view to how can we work with our colleges, our local construction industry, so that they can play a part in the build of the new hospital and the repurposing of our existing facilities. We won't be the employers, but we can contribute to helping with any training provision as colleges and local employers think about how they upscale their workforce. So that is in addition to our 62 new apprentices that will be joining us in September, a further 40 in January, healthcare, so these are taking a nursing pathway. We currently have 70 apprentices that will be nurses when these new hospitals open. It goes on, and our first integrated apprenticeship programme with Pembrokeshire Council.
Yeah. Thank you. Thank you. Steve?
Just to make the comment, I guess this is a really exciting discussion about getting this thing built and getting the wider ambitions of the programme business case realised. Probably less so about the individual pieces of land at the moment, which I know is what's today about, but there is a connection which I kind of wanted to make, which is something Lee said earlier, which is the more hurdles we have on any individual piece of land does run the risk of us delaying some of the benefits that Lisa and Ewan were talking about. So it's just to have that in our minds, that this is not just about making a decision today around moving forward, it's also trying to make the decision that will make it come to life as quickly as possible for our communities.
Yeah, thank you. Maynard.
Thanks, Chair. Lisa, you mentioned about transport and the survey about willingness to commute extra distances. I was just wondering whether there was any indication of preference by age in that, because a significant proportion of our current our current workforce is in the older category, and certainly I found the older I got, the less I was willing to travel a long distance to work.
We have got that data. I haven't got it at my fingertips now. So we have looked at the travel by age, by profession, by pay band, by male, female, so that we can have a look at what is the difference between all of those. And I think one of the things that staff find really difficult is we're talking over 8 years away, and therefore what's important to me today will not be important to me then. So trying to think about what might I want then is quite tricky, which is why for our workforce it is continuous conversation about what is it that we need to do to support people. And for me, the biggest piece of learning from this exercise is if that's important to them in 8 years, it's important to them now, and we need to do things now, actually, for some of the things that staff have said they want to see.
Absolutely. Yeah, thank you.
Thanks.
And any other questions on workforce? Thanks, Lisa. We'll go on to the next executive summary, and is that you, Hugh?
Diolch, Cadeirydd. Thank you, and I'd also like to thank the team who've been involved in supporting me on this, both internal and our external advisors. Clearly a significant piece of work undertaken by Gleeds on our behalf, and unlike me to be too quiet. Thank you. I'd like to thank colleagues from our external advisors as well. The report itself, we've got 2 pages there on the summary, but clearly a lot of detail behind that, and I would draw the board's attention to the independent assessment that we requested from PwC as well of our approach, and they concluded that we'd followed a clear approach and the underlying methodologies were robust and well explained, which is helpful, recognising that we're at an early stage and that there are significant risks that will emerge over time, not least the risk as we're all experiencing at the moment of inflation, and that will differentially impact on some of the components of the cost drivers that we have seen. In terms of the approach, we took a consistent methodology clearly across the sites, recognising the differential in costs that was the important point at this stage, not necessarily the absolute cost, in order to reach our conclusion. And there were 6 components, and I'll just reference those. So the land purchase clearly is something that everyone will recognise, but in the main, you know, that has as a component, it's between 20 and 30% of the total component, total cost driver. So it's not the most significant necessarily. Site conditions and topography often offset that differential in land purchase costs, and you add into that issues like drainage, incoming services and off-site highway drivers that were in many ways more than offsetting the differential on land purchase cost itself. The conclusion is outlined there quite clearly in terms of the capital cost assessment from the cost advisor, and in terms of the, there we go, I can click. So the capital costs have been assessed there and outlined. In terms of the revenue costs, the ongoing revenue cost of managing the sites was not considered to be different, and the potential short-term costs weren't identified as being significant from a revenue perspective over the lifespan of the new development. So we didn't consider that to be a significant driver to our determination. The last thing I'd like to highlight, it's been mentioned a few times, was the economic appraisal and the wider impact. So there are two elements to this. Firstly, we did not consider that there was a differential in the economic benefit or cost across any of the sites, because the zone of influence of the site would be so significant that it would offset any individual site location. But importantly, we didn't assess anything that might be speculative. So we didn't assess that there may be opportunities on one site over and above others, because they would have been speculative at this stage for us to consider further. So, Chair, that's where I'd like to pause, and happy to take questions.
Thank you, Hugh. Any questions? No, thank you. The reason there aren't any questions is the evidence that we have been presented in our packs and considered thoroughly is very extensive. So thank you. Okay, so that brings us to the end of the presentation of the appraisal workshops. Lee, do you want to add any more?
So there are a few subsequent slides that just kind of draw together the key questions around safe, sustainable, accessible and kind. Sorry, my microphone. Which I think draw out all the points that we've already covered. Thank you, Hugh. So I happily skip to those and just to summarise the key points, if that's okay. Thank you very much. So I won't take up much more time because I know we need to get into the discussion, but just to go back to our framing of this. So we, through the strategy, we identified safe, sustainable, accessible and kind as the key points from our public and our staff when we're trying to consider the services we want to be delivering in the future. So we tried to summarise then some of the key points from the work that we've just described in detail, just to bring some of that together. So I'll just quickly summarise. You've seen this information before, but from an accessibility point of view, we know that the vast majority of our population, which is why we selected the zone, can access the new hospital within an hour, irrespective of where it sits within the zone. But we do recognise that 2 points. Firstly, that there are some areas within the geography that are more challenged than others, so particularly the Pembrokeshire coastline, North Pembrokeshire, and then North Carmarthenshire as well, and obviously the impact on those differs depending on the exact location. When you look at accessibility, you can look at it in two ways. So just to draw out some of the transport information, the analysis shows that on average the additional travel time to the sites would range from 11 minutes down to 6, and that's a sliding scale west to east, and that isn't a surprise in the sense that our population is skewed towards the east, so therefore the average will naturally be weighted in that direction. Alternatively, you can look at the more extreme travel implications, so when you compare what people currently have to travel to what they might have to in the future, that we've done that analysis equally. You can see that a good proportion are about the same, and there are some areas where it's a bit quicker, but predominantly there is a longer travel time, as we've just picked up. But if you look at that 20 minutes plus line, then you can see that there is a differential between Whitland in the centre having the least impact, and then Narberth, and then St Clair's. And again, that's not a surprise because Whitland is in the middle, so it will have less of an impact across those two extremes, if you like. The safe, sustainable component, we've drawn that together. So we've particularly picked out the birth figures that we just talked about earlier, so just to bring that to people's attention. The top line is if we did the birth analysis, ignoring anything other than travel time. So if we only went on the basis of travel times, that would be the number of births in the new hospital. On top of that, you can consider the 400 or so births that go to Bronglais. So when you're talking about the 2,500 threshold that Phil referenced, you can see what adding 400 on top of that would make. And then the bottom line is if you add that 10-minute tolerance into it, what difference that makes. So you can obviously see the implication then of the exact sighting on both the range of potential birth numbers that we're considering. Stroke, as we've said, was less conclusive, albeit there was a bit of a sustainability skew towards the east of the patch, and workforce, as we mentioned, was inconclusive. So there's nothing particularly to draw from that in terms of that safe, sustainable criteria. So I will finish there. Thank you, Chair.
Thanks, Lee, and thank you and all your team and all your colleagues for the intense and comprehensive work that's been done to date on this, so that we can make the best reasonable decisions today. So thank you. I'm going to open up, in fact, I'm going to open up with a question. One of the recommendations is that we approve a recommendation relating to the need to commence a public consultation process, and this concurs with the CHC and follows the UHB duty under Section 183 of the National Health Services Wales Act 2006. And the consultation scope and questions will be determined following board decisions and discussion with the Hywel Dda CHC. So I'd like to open up to views on going out to public consultation at this stage. Judith.
Sorry. Yeah, thank you. I just think this is such an important issue, and we aren't really in a position to say this is definitely the best. I don't feel able to do that. And I think picking up the point I think that Delith made earlier about the number of people and the range of people who have got us to this stage, and, you know, huge thanks to them for giving up their time to do that. But I think to get maybe a wider range of views through different methods, I think would be positive and would enable us to make a correct decision. So I would actually be in favour of consultation.
Thank you. Phil.
Yeah, so I agree with Judith on those points. I think the other thing I wanted to raise related to this, and it relates to something that the Chief Exec said earlier, was around in making our choice of site or making our choice of what would go out to consultation. We do need to bear in mind, particularly bear in mind how which ones would have a particularly protracted timeline or likely to have a big risk around them. And that's not only because of risk of delaying the advantages around the workforce that we heard from Lisa's presentation, but it's also around the risks we have around our clinical services right now. And at the moment, the timeline stretches to 2029, which, talking to our clinicians and looking at the sustainability of our services, 2029 seems quite a long way away. And we know all the advantages. We've talked about the concerns particular positions around sustainability of services, but we know all the advantages, as we've rehearsed many times around this board table, of the having sustainability of services on the one hospital site. So I'd be concerned if the board felt that some of the sites or one of the sites might have a protracted timeline, pushing back us further from 2029.
Okay. And in your professional opinion, or the professional opinion of your colleagues, which sites or site do you think would have a protracted timeline?
So I think from my perspective, and I suppose it's less of a medical professional opinion on this and clinical professional opinion, but when we look at the risks, my concern, not being an expert, but looking at the risks around Site J actually, particularly, and you know, I'm only taking the advice of others. It does look like that could be a real challenge for us and a risk to the process. But you know, I'm probably probably not the qualified to know whether that you know, I'm taking the advice of colleagues on that.
Steve, you want to come in?
Yeah, just sort of building on that point, and I think the risk scores are, it's quite easy just to look at the number, isn't it, and just think that numerically it's something, but actually behind that is a whole set of things which do link to the discussion we had around not just ensuring that we secure the opportunity benefits from all of this, but that we are managing a very challenged system in the meantime, and that is likely to get more challenging. So those risk scores for me are really important. There are a couple of things I just wanted to say in relation to the consultation, and I think absolutely agree with all the comments that the Vice Chair's made about wanting to go out on this. I think we've characterised our whole approach to this strategy by wanting to ensure that we are fully inclusive, and I think, as I said at the beginning, we've done that so far, and this will be a continuation in that tradition. But that we ensure we go out to consult on issues that we feel the board is able to support, so that it's a genuine, heartfelt and open to, amenable to change as a result of what we get in feedback. And I think that's just something we all have to have in our minds today. And I was just linked to Phil's point around sort of clinical sustainability in the short term. I was going to ask Lee just to give a bit of a view about the likely timescales around consultation, not to argue against it, but just to ensure the board is aware of that, because every step we take on this, and today will be one of those steps, will help our clinical and our other staff, because it gives a bit more hope that that we're going to be able to achieve this. But clearly a consultation will delay to some extent making the next step, and we just need to be cognizant of that today. So Lee, I don't know whether you can comment on that. Yeah, absolutely. Thanks, Steve. So on the consultation, I think there are 3 points for the board to be aware of. So one of them is it isn't a free good. It will require some cost and investment to support that. So we just need to be aware that that will be part of what we bring forward to board at a subsequent date, should we agree to proceed with consultation. Secondly, the timeline. So that will be a discussion for us to have with CHE colleagues, is exactly what the consultation process would be, and the duration of each of the stages. But we should anticipate that it would likely take us in the region of 9 to 12 months to fully complete that from where we are today. And that's even with us bringing back to board the earliest opportunity what that consultation plan would look like. So we would be intending to bring that back to September board, so that we can get progress with that as quickly as possible. What I would say, though, is that this doesn't have to be a purely sequential process in that sense. We can continue with some of the planning work and some of the site investigations in the background. But that does take me back to the previous point around the cost implications of doing that across multiple sites. So that will be another factor for us to bear in mind. And that won't be a cost that we would be able to bear as a health board. We'd have to have that agreement with Welsh Government. And therefore, of course, that brings a level of uncertainty to it as well. And the third point I was going to make in relation to that, just for board to be aware, is, of course, with any implications to timeline, that doesn't just impact on
the hospital itself, but it increases the risk that we could lose one of those sites during that period because we won't have any hold over those sites at this stage. So I only say that so board members are aware of it, because my position is that we should go out to consult for the reasons mentioned. It's 4 years since we've last done that. We want to be open and transparent, and I believe firmly that that the wisdom isn't in this room; it's across all of our populations and all of our stakeholders. So I'm fully supportive of going to consultation at the next stage.
Okay, thank you. Dalith.
Diolch, Chair, diolch, Lee. As part of the consultation as well, I think we need to be cognizant of our primary care colleagues and our community services, because this is not just a new hospital build, because that will have a major impact on our structure and the way that patients access our secondary care. So I'm making a plea, really, that as well as the seldom heard voices of our public, we make sure that we hear the seldom heard voices of our GP and primary care colleagues as well, because there is that issue about our throughput and also our pathways. So,
thank you, Dalith. I'm going to bring Jill in.
Thank you, Chair. And I think that's a really important point, and just to stress that we have held sessions with our GP leads around this and invited other clinicians to those conversations. I think the important point, though, to add, and it was part of our experience 4 years ago, that whilst we'll be very clear with the public that we are consulting on the specific location for a hospital, what the public really want to know is what services are going to be available local to them. So when they're considering that decision around a new hospital, that's one of the things that I think we're going to have to be able to discuss with the public in terms of what remains within the existing hospital sites, but also the development of our wider primary and community services, which we know are changing. We've got an accelerated cluster delivery programme. We've got far more integrated services than we had previously, but equally, as the medical director has referred to, we've got challenges regarding sustainability within our primary and community services, as well as within our acute services. So all of these factors will be really important to the public in making that decision. But just to confirm, it's an important point you've made, Dalith, and we have been bringing our clinicians into those discussions.
Thank you, Jill. Paul.
Yeah, I think the point that Lee makes in relation to not having to deal with all of these steps sequentially is really important. I think consultation, I think, seems to be inevitable, and to that extent is probably a no-brainer. But whilst we are going out to consultation, that shouldn't be effectively a 9 or 10, 12-month dead period, as it were. There is a lot we could be doing about finalising the information that we need about each of the remaining candidate sites, discussions with the landowners, and taking steps possibly to enter into agreements with them that would secure those sites, so that as and when we come to the conclusion to the process, that we're then in a position to actually move forward with that more quickly, rather than us having to sort of enter into all those negotiations at the end of the consultation period.
Yeah, absolutely. Steve.
And just on that, I guess it's worth reiterating then that the numbers of pieces of land that we take forward will probably have more of an impact than the consultation itself in terms of the timeline. So it's just having that in our minds.
Yeah, thank you. Ewan.
Thanks, Chair. Yeah, just agreeing in terms of what Jill was saying. I think whichever kind of sites we take forward now into what I would kind of say a continuation of our public consultation. It's not a commencement, because I think it's been done since 2018. I think, as Jill was saying, I think what we need to very much communicate, regardless of the sites which we kind of put on the table for our public and wider kind of stakeholders to consider, is that information which is in relation to the existing sites, because I think that's really key to our population in terms of, what investment is going into Withybush, what investment is going into Glangwili, into those new community centres, because I think those of us who went to the evening session, which Hywel Dda kind of did earlier this week, when that information was relayed to the town and community councillors from Pembrokeshire, one of the Pembroke Dock councillors very clearly articulated, we weren't aware of the additional benefits that were coming from this wider programme. Everything is always fixated on the new hospital, And in addition to the new hospital, I think what we need to make sure the public is aware of is, okay, what services are moving, but what actual investment is going into our existing sites as part of this plan. And I think that'll be a key part of our consultation, and should be, that whilst we're looking to kind of get the guidance from the wider stakeholders and partners within our region, it's also the changes that we'll see for the good in many of our other sites, which will, I think, help inform that decision and kind of recommendation from our wider consultees in terms of where we go as a board.
Thanks, Ewan, and thank you and your organisation for hosting those meetings with the town and community councillors in Pembrokeshire and the third sector on Monday. They were very useful, so thank you. We've also got one of our board members who couldn't attend today, and she sent in a comment, so I'd like to share them so that they're heard publicly. If I could go over to you, Jo.
Thank you, Chair. Thank you, Chair. I'll read them out directly so that these are directly from Anna Lewis, our Quality Chair. So Anna's currently unwell today and therefore isn't able to join us, but has, however, sent in her comments to be formed part of today's deliberations. They are more in general as part of the comments now while the presentation's been concluded. So Anna notes there's not an overwhelming clear option, and thus the determination will come down to a judgment from us as a board, with that judgment being made as rigorously as possible, with this being a unitary process of scrutiny rather than a consensus amongst individual board members. The same rigour should also apply to the decision to move to the public consultation. It feels intuitively right to do so, and this is supported by Anna. Anna also asked that the record show in what respects a decision reaches the threshold for consultation. She believes that it would be wrong to put any option into consultation which is clearly unfeasible, and in doing this the board would not be fulfilling its statutory duties. In conclusion, this is about having a robust and transparent process which we can assure from which the decisions about sites will naturally flow.
Thanks, Jo. And I think we've also had comments from the Stakeholder Reference Group.
Yes, thank you, Chair. And Hazel also sends her apologies today as the Chair of the Stakeholder Reference Group. So Hazel has asked for the board to make sure in any deliberations the feedback from the SRG meetings with the key points being transport, accessibility and staff accommodation. The SRG stressed the importance of stakeholders being engaged as more details emerges and decisions are made so that they can advocate for messaging around developments and progress. The SRG asks that any questions or issues raised with partner organisation or any rumours heard can be shared with our Communications Director so that we can provide some reassurance to our public. The SRG also agreed that the new urgent and planned care hospital project is an agenda item for their meeting in November, and they will arrange an additional meeting if necessary as this progresses.
Thank you, Jo. Are there any other comments before we have a Mansell?
Yeah, thanks, Chair. I think it's important at this juncture that we put the Community Health Council view over. We've been involved in this from the very beginning. It's been an interesting journey, to say the least. We were involved in the 12 to 5, only from an observation process, and when we got it down to 5, when it was down to 5, the public were asked to score on the 5. And recently, we've had an exec meeting based on the presentation today, which kindly Lee came along and gave us another 20 minutes. It was a unanimous view by the Executive Council, the Community Health Council, that you should go out and consult on 5. Mainly because if there's the only evidence that we heard different so far is a bit of the clinical. The only time we saw the clinical side was when Lee gave it on Tuesday, to a certain extent. We weren't involved in that because we're lay people, we're not clinical. So that's the key. I'm very pleased to hear that the board is open to the consultation. I think that's very important. I think it's been done like that all the way through. Our colleagues mentioned about 2018, which is something we've been on about for some time. The public forget what's happened in 2018. In fact, some of the questions that came out at the technical review was, what's happening with Prince Philip, what's happening with Bronglais. And it was important, I think, that perhaps that should have been come across a bit earlier. The centres or the hubs, I think, are very important. The fact that Llandovery, those areas outside, not just Pembrokeshire, but outside further in Carmarthenshire and indeed Ceredigion, who I think sometimes think that nothing's happening, Bronglais is staying as it is, same as Prince Philip. This will have a significant effect on Bronglais and will have a significant effect on Prince Philip, clinically wise, as we've heard today. So from our perspective, it should go forward on the 5. However, if the board decides to go out on less than 5, then it's important from our standing orders that we meet urgently with your executive team so that you can give forward the evidence to our members and to the public why you're doing that. Thank you.
Many thanks, Mansell. And we will obviously take that into account when we come to our decisions today. And thank you for bringing that voice to the table of the public that we collectively serve. Thank you. Are there any other comments? Phil?
One comment just related to a point that Lee mentioned earlier, which I just wanted to check on, was that if we consult on 5, for example, I think Lee said that we would therefore need during that time to be preparing our work on all 5 through our development to the outline business case. And I'm assuming that there are a number of potential challenges around that. One would be cost, and therefore the more cost and more complicated the outline business case development is, that I wonder whether that would have an implication on the likelihood of Welsh Government support for all those next steps, if it was higher cost. And therefore might delay decision making on us moving to the next stage, and that would then lead to me having the same concerns as I had earlier about delays in the programme of work.
Yeah, thanks, Phil. And could I also ask a question on that point, as well as cost and potential delay and Welsh Government support? Would it also impact on the capacity to do that work? You mentioned in the SBAR about external and internal. Oh, sorry, Lee, over to you.
Yeah, absolutely. So there's 2 aspects to this. One is sorry, thank you. The land process itself, and then related to that, in parallel with that, is the work on the development of the outline business cases. So for each site that we take forward, and bear in mind, of course, I said that if we through a consultation process, we're not likely to come to a definitive conclusion on the results of that for maybe 9 to 12 months. Then if we're going to continue to progress that work, we're going to need to, there are going to be different points along that journey where we're going to have to potentially incur some costs associated with that. So those costs would be both in terms of our planning process. So one of the rate limiting steps in getting the 2029 date is we're likely to need to do, or expect to need to do, 12 months of ecological studies on a site before we can submit planning permission. That is a rate limiting step. So that will present us with a choice as to whether we proceed with those whilst we're consulting, for every site that we're consulting on, and therefore incur the costs associated with that, which will be in multiple hundreds of thousands per site, just to give you context. Or the alternative option would be for us to allow all of that to conclude in terms of the consultation process and so on, and then do some further work and delay the planning permission thereafter. But of course, as Paul says earlier, what we'd really like to do is bring all the information together and get as much information as possible, so that in 12 months' time we can have conclusive decision, and so on. So I would want to progress with as much as possible in that time, and therefore there would be a cost implication to that. Equally, the other point on that is if we wanted to secure our position on any of those lands, then we'd have to reach a contractual agreement with each of those sites and landowners.
Sorry, I didn't hear that point. Could you repeat that?
Yeah, so if we wanted to secure our position, and by that I mean protect our ability to purchase the site at a later date, take an option out on any of the sites, then we'd have to negotiate that with the relevant landowners, and clearly the more sites, the more cost and the more complications associated with that. So that's the land acquisition. And then in parallel, the outline business case work, we can progress with the pathway analysis work as much as possible, and we'll be looking to do that. But as we've seen, for example, through the obstetrics and pediatric conversation, but the same applies to every service, exactly where we site the service will make a difference to the size of the services that we would need to put in the hospital. And at outline business case, we'd be wanting to get to 1 to 200 scale plans for the new hospital, if you see what I mean. So that isn't up to this point. It's been quite high level. We're going to need to get into a lot of detail as to the configuration of the new hospital site, what would go where, what size it would need to be, and so on. So clearly, we can only go so far with that until we know the location. The exact site is probably less important than the location, if you see what I mean. So if we've got 2 sites in Whitland, that the difference between those 2 sites will be marginal for that piece of work. It's relevant to the land acquisition, but it's much more important as to whether we would choose, say, a Narberth, Whitland or Sinclair site.
Okay. Thank you, that's really helpful. And one of the points that you made there about what goes where and that detailed planning is coming out loud and clear in the public meetings. The public want to know, and quite rightly so. So that's a material consideration for us as well. Are there any other points people would like to make?
Yes,
Donna.
On behalf of the CHC, our perspective is we're here for the people, and we understand that there's a rational economic imperative here that you have to consider. We have to be practical, but at the same time, I just want to emphasise that from our perspective, there were 5 viable sites that were scored, and if now there's not 5 viable sites going to move forward, the public need to understand why that is and be fully kept abreast of that for transparency.
Yeah. Thank you. Very helpful, Donna. Thank you. Any other comments? Ewan.
Chair. Yeah, I totally agree with colleagues from the CHC in terms of the public, absolutely need to understand where we're going on this. But I think let's kind of look at it from a different angle. We as a board have a responsibility now to look at the recommendations going back to the public to make sure that engagement is clear, concise and transparent. We've already gone through a consultation, albeit through a smaller kind of enclave of consultees. But they have scored those 5 sites which we've been presented with. I would be nervous in terms of going as if we're kind of saying, well, we're not ready to make that decision, back to you. I think we have to take leadership and ownership of this as a board. And I think we have to kind of look at whittling it down to potentially 3 or 4 at the most. I think from the scoring and from the risk assessments, for me personally, it's clear which one would drop out. And I think we can go back then to the public with a more robust, accurate and meaningful consultation to engage them in that dialogue with us. And we can then kind of say the reasons why we're putting these forward are very clear in terms of our direction of travel. The timing I'm nervous of, because I think we lose momentum further down the timeline for delivery for this, for our kind of region. But I think it's really important to make sure the public are with us and they can see that we're taking ownership, accountability, and we're looking to engage. So I think I personally wouldn't like to see these 5 go back to the public again. They've gone through consultation, they've been risk assessed, they've been scored. I think we have to take a strategic decision which we need to own as a board and go back to the public for a full consultation, but on a smaller number of proposals.
Thank you. Lee.
Quick point just on that. We just need to be careful around language. So we consulted in 2018 on the strategy and the zone came out of that. we haven't consulted on these 5 sites. We've engaged the public, and we've involved them in the discussions, but we haven't.
Yeah.
It's just a formal legal definition and a use of words that's important.
Yeah. Many thanks. Mansell.
Yes, thanks, Lee, for that qualification. I think that's important. We know, and the public know, that as you go along, you'll be teasing out more evidence on why perhaps certain sites shouldn't be. My concern is on the technical side, and I was observing that, is that the bar was set as such that we were told that don't worry about the cost, don't worry about phosphates, don't worry about this. If we can build on it, then it should go forward. And that's how these sites have gone forward. Now, if the site, whatever it is, J was it, I think was the lowest one, then perhaps that gives a bit of a qualification on perhaps if the bar had been set a bit higher, then perhaps J wouldn't have come into this qualification anyway. But that's what my concern is that the public were asked to score on the 5, and that's what we've done. I fully understand the prerogative of the board on what the gentleman has said over there, but I think that has to be followed up, as we said, with the viable evidence to the public on why we're not taking that site, or why you're not taking that site forward. Thank you.
Thank you, Mansell. Steve.
Yeah, it was just to come. I agree, Mansell. We need to be absolutely transparent at every step of this, and I think it was just to acknowledge in the discussions that were had with the CHC, it was around the technical appraisal process. What we've heard today are a range of other things as well that need to come into play, particularly the clinical. It's just to put that on the table that there are other angles that the board will also need to look at. But I absolutely agree with what you say about how the technical appraisal worked. I think Lee said at the beginning, from that point of view, they're all viable. But there are other considerations I think we've heard today that we need to take into account.
Just make one point of that. As you say, Ansel, in the discussion, I think we were trying to obviously score them to get an understanding of for us to be able to make this kind of decision. So we're always going to be in a situation where we're going to use that information to eliminate one side or another. That was obviously the intention of it. And in the workshop, you probably recall there was a bit of a discussion actually about whether Jay should have got that far, because there were some significant reservations, and part of the reason it did was because those limitations and concerns came out through further investigations over coming months. So I think there are some material issues with Site J, which is reflected in the risk score and reflected in scoring from the public, that we should take account of. I think that then leads us to make a decision on it. At some point, we have to make a decision on the information, and I think we've got a good level of information from the public and from that process as to whether that site is viable or not.
Thank you.
If I may come back quickly. I mean, this is a once-in-a-lifetime opportunity for the public to have a say in this hospital. And it's a two-way street, because they will influence, but it's important that the health board influence their decision, influence them on any decision that they may make. Simple as that, really. Yeah. Thank you.
Thank you, Mansell. Any other comments? Okay, we're going to have a 10-minute break and come back, and then I will summarise our discussions and put to the board some choices and to make decisions. So thank you. Thank you and welcome back. I'd like to thank everybody for the debate this morning and the work that has gone on for many, many, many months. And I'd just like to summarise where I think we have arrived. Today, after many years of listening to and consulting with the people of West Wales, we agreed our strategy, our promise, a healthier mid and West Wales, at the end of 2018. And since then, we have faced the global pandemic, which is the greatest challenge that we've ever faced in the NHS. The care, the dedication, the courage and the sacrifices of everyone in our health board has been humbling and incredible, and we must never forget that. During the pandemic, work did, however, continue in planning how we will deliver on our promise, our strategy, to make sure that we have the best health and care service that we can have in West Wales. As you know, in January 2002, we as a board agreed our programme business case, which sets out at a very high level how we intend to deliver our strategy, and we have submitted this to Welsh Government for its approval. We've asked for £1.3 billion of investment in West Wales. And as we've heard today, and we hear often, this is an opportunity of a generation, an opportunity for now and for future generations to come, which will shape and transform care in West Wales. If we are successful, this is the greatest investment West Wales will ever have seen. And we must remember, and it's been referred to today, the foundation of our promise, of our strategy, is to bring as much care as possible closer to our homes through integrated health and wellbeing centres. And already we have set these up successfully in Aberaeron and in Cardigan, and we have an ambitious programme for them to be in many towns in West Wales, such as Crosshands, Fishguard, Haverfordwest, Milford Haven, Neyland, Llandovery, Carmarthen, Narberth and Tenby. As a health board, we are committed that we will continue to deliver those integrated health and care centres. And these will be designed with local communities, responding to local need. And our ambition is to have these in place before any changes to our acute hospitals. Part of our strategy and promise, which we have looked at today, includes a new urgent and planned care hospital between Narberth and St Clair's to attract and bring together a critical mass of staff to provide more services in West Wales and better care. Today we are deciding, based on the detail and the evidence provided, which site or sites the new hospital may be built on. We have listened to and we will continue to listen to the fears and the voices of the public we serve and our staff, who understand more than anyone the frontline real challenges of trying to deliver services across so many sites, spread so thinly, and who are doing their very best. And we promise as a board that we will continue to listen and take all those views into account at every stage of this journey. Whilst recognising the fragility of many of our services and the risk this presents to us every day now, it's important to emphasise that we do not intend to make changes at Withybush and Glangwili hospitals before the new hospital is built, and afterwards they will continue to provide valuable health services to their local communities. So before us today, after a long and comprehensive process, which has been certified as best practice, set out in the papers, we have the evidence in respect of the 5 endorsed potential sites, 2 in St Clair's, 2 in Whitland and 1 in Narberth. And we've heard how there were 4 parallel appraisal groups. Technical, with a majority of public members, considering whether a site is capable of supporting the development of a new hospital. Finance and economic, considering the variation in cost in building a hospital on each of the potential sites. Workforce, the impact on current and future workforce by each potential site. And clinical, whether a site can provide a safe, sustainable, accessible and kind services. And in particular, we heard today the needs of pregnant women and babies and children's services and stroke. These appraisals have been conducted with the purpose of providing evidence to us, the board, which might allow us to eliminate a site or sites from the next stages of the work. And we have considered the outcome of all of them in detail, not only today, but throughout this process when they have been available. We have heard from the CHC that they wish us to consult on all 4 sites. And we will take this into account when exercising our duty as a board to consider all the evidence before us today. 5 sites, excuse me. Thank you, Mansell, to inform our conclusions. It wasn't a slip of the tongue, 5 sites. We will also take into account that the number of sites retained will have significant cost implications for the taxpayer, and as we heard in our debate, may cause delay in the building of a new hospital and developing the detailed pathways of what goes where, which is so important to the public who we serve and to our staff. And we will consider the appraisal workshop outcomes through the Health Board's strategic objectives, which are to provide services which are safe, sustainable, accessible and kind. So turning to the evidence. Technically, the lowest scoring site is Site J at St Clair's. The other sites score very closely to each other in the technical appraisal evidence. And we've heard that this is a 10% meaningful difference in Site J, and the technical risk score is higher at 171. On the basis of that evidence before us today, does the board approve it is reasonable to eliminate Site J at St Clair's from further consideration? I can see everybody is nodding. Yes. Any objections from the board? Okay, thank you. The clinical appraisal work stream undertook an objective assessment of the clinical implications of siting the new hospital at the east, west and central locations of the agreed zone. The attendees of the workshop were concerned that the zone would present a clinical risk to the delivery of services due to reduction in birth numbers, neonatal admissions, including days of respiratory care provided, and acute paediatric admissions, with reducing critical mass for a safe and sustainable service. Further, that the service that can be provided will reduce if the number of service users are reduced, and that a Narberth location is likely to lead to a reduction in patient numbers and births below 2,500, and that a fall in birth numbers will directly impact the sustainability of the service. We also see in that evidence that was put before us today that in relation to time-critical transfers, for example, neonatal intensive care facilities, cardiac, etc., that these all go east, and a hospital in Narberth will result in longer transfer times. Currently, we've heard that live births in Hywel Dda are circa 3,000, just below. And the peer-held view is that with a reduction in birth rate, there is a potential threat to our training status and the ability to access trainee medical workforce. They also felt that the training status is linked to the number of neonatal respiratory care days and interdependency of birth numbers, and similar risks around the critical mass reduction in patient numbers and births from a nurse and midwifery training perspective. And we also heard the potential impact on health inequalities for our population in respect of placing a hospital further west. Of the 3 geographical areas appraised, we were informed that the area in the east presented the least clinical risk to services. The attendees of the workshop were of the opinion that a site even further east of the proposed zone would be preferable. However, the zone has already been agreed after extensive public consultation and is not part of this process. And we heard of the potential impact on the capacity of Swansea Bay, the further west the site was. With stroke, looking at the detailed evidence within the appendices, when questioned, will the western area Narberth allow for safe, sustainable, accessible and kind services for the majority of stroke patients, the response of the majority of participants was no. The participants were asked to rank the areas between 1, the best, and 3, the worst. Narberth received the lowest score, and in the ranking poll was considered unanimously worst. In the face-to-face workshop held on the 29th of April 2022, most of the participants felt Narberth could not provide a safe, sustainable, accessible and kind area for site in a hospital. And while there was no clear split in the rankings between the east and central zones, in the individual polls there was 100% agreement that the east could provide safe, sustainable, accessible and kind care. And the general findings for the stroke services, although I've gone into some of the detail there, is any of the areas would be suitable with pathways, in particular how patients are treated beyond their admission being more important than location. A central or east site would be more preferable due to access to workforce. These are material considerations for us as a board when deciding on the sites, and there is no evidence before us which outweighs them in relation to access, workforce, financial, economic or technical. So does the board approve on the basis of the evidence before us and taking into account our strategic objectives of safe, sustainable, accessible and kind services that it is reasonable to eliminate the site furthest west, site 7? Yes. Unanimous agreement, thank you. I can move on to the workforce appraisal. This provides us with evidence on the assessment of the implications on workforce for the geographical locations of the shortlisted sites and the categories of workforce explored. And as we've heard today, the general findings are there's very little difference between the identified sites in terms of recruitment, and it's inclusive to say that a site further east in the zone will have a greater impact on securing a sustainable workforce. We also heard loud and clear today the voices of our staff of what they wish to be improved upon and put in place to enhance their experience working in our health board now. And as with all the evidence, there's rich data there to us to improve what we do now as we are building for the future. Similarly, the financial economic evidence finds that there is little to distinguish between the 2 least costly sites, and the percentage of the overall estimated cost between the least and the most costly is in the range of less than 2% of the total cost of the development. And revenue costs have been estimated to be the same regardless of the site, and it's not possible to determine if the economic benefit would be different depending on the site, given their proximity. So if I could now turn to the recommendations. We've considered the evidence provided through the appraisal work streams in relation to the 5 shortlisted sites, the opinion of the CHC and our strategic objectives. And we've determined that sites 12 and C at Whitland and site 17 at St Clair's should be taken forward for further consideration. We note the continuing development of the Equality and Health Impact Assessment, and we note the best practice certification for the land appraisal process from the Consultation Institute. We've discussed going out to public consultation, and there was unanimous support from this board for going out to give the public a voice on those sites which we believe are the best sites based on all the evidence before us today. In particular, we heard how important it is to hear the quiet and the seldom heard voices, and the voices of our staff, particularly our staff in primary and community care. And as I said at the beginning of the summary, that is the foundation of the care that we provide and our programme business case going forward. And we promise to meet with the CHC as requested following this meeting to discuss in detail why we have chosen those sites, and I'm very happy to provide a copy of my summary to them once it's complete. And we note the risks identified through the appraisal work streams on the technical risk assessment and the need to work closely with Welsh Government colleagues in relation to the land selection process and decision-making process. And we also heard from our board there is a plea that the work continues simultaneously so that we can reduce the delay in view of the fragility of our current services to provide the best health care and deliver our programme business case in the very ambitious timelines that we have set ourselves. But I'd just like to conclude to thank everybody, in particular Lee and the planning team, very professional, very detailed, inclusive and transparent piece of work. And we as a board promise that we will continue in the same vein to deliver this programme business case. So diolch yn fawr, everybody. And I think that brings the board to a close. Many thanks.